teacher trainings. And lastly, we are recording today's webinar, and we will post it within the next week on our CIMH YouTube channel. And we'll also send you that link, so if you want to refer to this in the future, we're happy to have you do that. So it is a privilege to have with us today Beth Phoenix. Dr. Beth Phoenix is a health sciences clinical professor at the UCSF School of Nursing and program director for the Psychiatric Mental Health Nursing Graduate Program. She received her master's in psychiatric nursing in 1990 and her PhD in nursing in 1997 from UCSF. Dr. Phoenix has been the principal investigator on several HRSA training grants to improve innovative educational programs at UCSF, including development of materials for interdisciplinary management of depression, provision of trauma-informed mental health care, and blending primary care nurse practitioner and psychiatric nurse specialist roles to provide integrated care for persons with medical and psychiatric comorbidities. She currently serves as the immediate past president of the American Psychiatric Nurses Association and received this organization's 2009 Award for Excellence in Education. She was also recently inducted as a fellow of the American Academy of Nursing. So at this time, it is my pleasure to turn the presentation over to Dr. Phoenix for her presentation. Thank you.
And thank you for that kind introduction, and you know, thanks to everybody for attending. And we will have a question and answer period about halfway through, and then at the end, depending on how much time we have, in addition to questions, we may have an opportunity for some discussion. So I'm really looking forward to, you know, having a chance to hopefully hear from some of you. So let me get this to advance. My PowerPoint is not advancing, unfortunately. Oh, there we go. Okay. So these are the objectives for today's presentation. I think you can read them on your own, but I want to really emphasize kind of what are some of the similarities and what are some of the differences in scope of practice for psychiatric nurse practitioners with other mental health professionals, and then talk about the value that Psych NPs can bring to behavioral care teams, and then sort of look at some roles that currently exist and some potential innovations for the future. So, so these are the categories we're going to cover. We'll talk about, you know, what a Psych NP is, how they can contribute to the behavioral health team, and then look at education and the regulatory framework for practice, and then we'll pause for questions, and then we'll really look more at, you know, what does this role look like in different settings where it's being implemented. So just to define the role, a Psych NP is a registered nurse who has received graduate education in a Psych NP program, and in many cases is also nationally certified as a psychiatric mental health nurse practitioner. And as compared to the basic RN scope of practice, Psych NPs have an expanded scope of practice that includes psychotherapy and medication management. And the kind of overall sort of umbrella concept for the Psych NP role is providing primary mental health care. And there's a definition of this here that sort of really, it emphasizes the behavioral health focus, but also considering that within the context of the person's total health status. So psychiatric mental health nurse practitioners are different from other types of nurse practitioners who are prepared to work in primary care or acute or specialty settings, because the focus of this role is specifically on behavioral health. And I want to really emphasize that this is an advanced nursing role, and that the obtaining this expanded scope of practice does not mean the loss of the nursing perspective. And I want to just read the definition of nursing from the American Nurses Association, just to kind of give you a flavor of what this means. So the definition is that nursing is the protection, promotion, and optimization of health and abilities, prevention of illness and injury, alleviation of suffering through the diagnosis and treatment of human response, and advocacy in the care of individuals, families, communities, and populations. So I think a key point in this is that this focus on human responses to health conditions, and that as nurses sort of gain additional expertise in diagnosing sort of a psychiatric diagnosis, that they do not lose their focus on the human response to behavioral health conditions. So this slide is not an exhaustive list of the functions that go with the Psych NP role, but I think it hits some of the highlights. So assessment, developing a differential, coming up with a treatment plan, psychotherapy, med management. I think a growing role for Psych NPs is going to be providing behavioral health services in general health settings, and then some additional kind of advanced nursing functions such as consultation and research. And just looking at the, what the Psych NP's contribution can be to a behavioral health team, I think one of the things that really characterizes nursing is this broad-based approach to health, and a broad-based understanding of different health conditions and skills to deal with them. So biopsychosocial is definitely one of nursing's favorite words that kind of gets thrown around a lot in nursing, because we really have theoretical training and an integrative approach to all these aspects, and are able to consider the impact of medical problems both in the differential diagnosis, but also in the treatment of patients with complex health conditions. And since nurses are present, pretty much across the spectrum of healthcare settings, we're familiar with, inpatient settings, emergency rooms, outpatient primary care. So there's a level of understanding different components of the healthcare system that nurses really bring, as well as the ability to speak the language of medical providers. And so nurses really have the education and experience to identify and either make appropriate referrals or even co-manage coexisting health problems, which is an extremely important contribution because the people who are served by the public mental health system generally have very poor overall health. And some of you may have heard the statistic that people with serious mental illness die 15 years earlier than the rest of the population. And actually, I read a recent study that indicated that that gap has actually gotten worse. It's now 25 years earlier than other people in the general population. So factors such as the side effects of psychotropic medication and metabolic syndrome certainly contribute to this. But it's also true, and has been true for many years, that the population that's seen in public mental health may have poor health habits overall, such as smoking, high rate of smoking, poor diet, substance abuse, and some of those things that contribute to developing chronic disease. So Psych NPs really bring the strong nursing foundation of health education, health promotion, which I think is really important. And in addition, because Psych NPs do have prescriptive authority, Psych NPs really can potentially help to alleviate the prescriber shortage. And I think that as we're looking at the beginning phases of the Affordable Care Act rolling out, obviously with the improved coverage for mental health conditions, a lot of people with mental health conditions who have not been able to afford treatment before are going to be entering into the system. And the number of psychiatrists being trained is not really increasing that rapidly. But the number of nurse practitioners overall is expected to approximately double by 2025. So there's definitely capacity to increase the number of Psych NPs more rapidly than other prescribers. So I also want to mention that there is a substantial body of literature that demonstrates that the presence of nurse practitioners on healthcare teams improves the quality of management of chronic conditions. And most of this literature is on primary care conditions such as diabetes and hypertension. But I think that the sort of the principles that the contribution that NPs make in other settings would also hold true in behavioral health. And I just want to quote a sentence from a study of diabetes care that found that family practices employing nurse practitioners performed better than those with physicians only and those employing physicians assistants, especially with regard to diabetes process measures. So, I think this points to a unique contribution that advanced practice psychiatric nurses can really bring to behavioral health teams that's been largely lacking in the last 20 or 30 years. So this is a little pie chart that sort of demonstrates some of the areas of the psych nurse practitioner scope of practice. And it's certainly not all the functions that Psych NPs have. I just, if I made the pie slices any narrower, I wouldn't have been able to put any text in. But I think this sort of helps to conceptualize what the scope of practice is. And also, as we'll talk about later, not every job or not every student placement may incorporate all of those things. It may just include some of the functions within the role as a whole. So now I'm going to talk about Psych NP education and clinical training. And I have noticed that there's a few of my students or former students on the webinar, so they may be able to sort of contribute to the discussion about this. So I want to just start with kind of an overview. And this is the curriculum structure that's sort of defined by the American Association of Colleges of Nursing for advanced practice registered nurse programs. And this includes midwives, clinical nurse specialists, and nurse anesthetists, as well as nurse practitioners. So it's a three-tiered model of essential graduate curriculum content that includes a graduate core that all nursing graduate students take regardless of role, and then a clinical core with the content that's important for APRNs with expanded clinical responsibilities, and then specialty coursework that's specific to the student's role and population of interest. So the graduate nursing core includes, kind of basic stuff like research, theory and ethics, leadership, healthcare policy and economics. And so it includes epidemiology and public health content that's needed to assess health risks in specific populations. And then the clinical core includes, what we call the 3 Ps, or physical assessment, pathophysiology, and pharmacology, as well as assessment and management of common health symptoms. So Psych NP students learn how to do a comprehensive physical examination and a thorough health history, and to recognize and be able to manage or refer symptoms of common health conditions. And then the psychiatric specialty coursework is similar to that of other graduate mental health professionals. Covers series of psychiatric conditions, psychiatric assessment, psychotherapy, psychopharm, and then management of complex conditions, including substance abuse conditions as well as trauma-related conditions. So, so there's really an emphasis on kind of a comprehensive approach, and I think nursing is generally pretty eclectic as far as theories. So students learn neurobiological, psychodynamic, cognitive behavioral, and humanistic theories, and how these might apply to specific conditions. And then in terms of looking at what kinds of clinical experiences students need to go along with this didactic coursework, we start with the Psychiatric Mental Health Nurse Practitioner Competencies, which are published by the National Organization of Nurse Practitioner Faculties, as a guide to define the skill set that the graduates will be expected to have on graduation. So the Psych NP competencies define skills in 9 broad categories that include assessment, diagnosis, and treatment, and also look at things like negotiating healthcare systems and improving quality of care and health information technology. So I just pulled out a few sort of representative competencies, that sort of address different stages of the treatment process. And then in terms of clinical experiences that Psych NP students need, obviously in order to master all these competencies, they need exposure to a wide range of different clinical experiences. And the way our program is set up, I mean, this varies from program to program, but we usually in the first year of their program, they start with more didactic content and briefer, focused clinical experiences. And then in the second year of their program, they have a 9 to 12 month residency. And nurse practitioners in master's degree programs are required to complete a minimum of 540 clinical hours for licensure in California, although most of our students have significantly more hours than this. And clinical doctorate programs, the Doctor of Nurse Practitioner degree requires a minimum of 1,000 clinical hours, although some of these are spent in a capstone practice improvement project. So this can, the way clinical experiences are structured and the total number of clinical hours that are required can be a bit of an issue sometimes in Psych NP students being involved in multidisciplinary mental health training programs that require a more substantial time commitment, because oftentimes that's not really feasible for Psych NP students given the number of other competencies that they have to develop. So in terms of what we're looking for in terms of placements for Psych NP students, we prefer settings that provide a range of mental health services so that students can develop this broad range of skills. And obviously, willingness to devote resources to student training is an important issue. And generally, it's advantageous if the agency has some understanding of the Psych NP role, although we are certainly often training our students in settings that do not have Psych NPs on staff. So So sometimes that is something that students really need to be able to articulate to the agency, what their role is and what kind of experiences they need in order to develop that role. So in terms of preceptors, Psych NP students can be precepted by a variety of mental health professionals to develop skills in psychopharm, which would be psychiatrists or Psych NPs, or psychotherapy, which could be any mental health professional that does psychotherapy. And then we're also looking at the willingness and ability of potential preceptors to devote the time and attention that's needed to supervising the students. And the program faculty maintain contact with clinical preceptors throughout the academic year to monitor student progress and to provide consultation and support to clinical preceptors and agency staff when it's needed. So now I'm going to shift gears a little bit and talk about the legal and regulatory framework for practice. So some of you may be familiar with the new APRN consensus model, which is looking at standardizing some of these things across state lines, because currently there's quite a bit of difference from state to state in terms of title recognition and scope of practice and things like that from state to state. So I'm going to be talking about primarily the situation in California, although as we'll see in a future slide, the situation's pretty different in surrounding states. So California is one of the few states that don't require national board certification in order to become licensed. And for Psych NPs, the agency that certifies Psych NPs is the American Nurses Credentialing Center. And although it's not required for NP licensure in California, many payers require national certification for Psych NPs to bill for their services. So I think there's a growing movement towards requiring that. And certainly when the APRN consensus model is fully implemented, that will be a requirement. Now, in terms of licensure, nurse practitioners get a separate license or certificate once they complete a nurse practitioner program. Their license from the state does not specify their specialty. So from the point of view of the state of California, an NP is an NP. And then NPs also can receive a furnishing license. That's kind of a euphemism for prescriptive authority. And then on the national level, they receive a number from the Drug Enforcement Agency that allows them to prescribe Schedule 2 through 5 medications. So one of the things that's quite different in California from the other Western states is that California is the only remaining Western state that requires nurse practitioners to have a supervisory relationship with a physician. And I think that, there was a bill in the legislature this year that would have expanded the scope of practice not only for nurse practitioners but also for I believe optometrists and pharmacists, but that bill was not passed this year. But I think the momentum nationally is for nurses to be able to practice to the full extent of their education and training. And this was one of the key recommendations of the Institute of Medicine's Future of Nursing report. So it's, and I think in addition to this report, there have been a couple of other influential reports that recommend removing scope of practice barriers. The National Governors Association recently came out with a report it was focused on nurse practitioners in primary care, but it really looked at all the literature about safety and quality of NP practice and determined that that nurse practitioners have a very solid record of providing quality services. So patient safety, is not a concern in terms of removing scope of practice barriers. And then the nursing community is also engaged in this campaign for action in partnership with Robert Wood Johnson and the AARP to implement some of these recommendations from the IOM Future of Nursing report. So I think this is the way that things are moving in the future. I don't think it's going to change overnight, but I think that the body of evidence is really pretty clear that nurse practitioners, although they certainly benefit from collaborative relationships with physicians, really do not require physician supervision when they're practicing within their appropriate scope. So back to California. So basically the mechanism with which sort of spells out the supervisory relationship is called standardized procedure. And this quote is from the Nurse Practice Act. Standardized procedures are a legal mechanism for NPs to perform functions which would otherwise be considered the practice of medicine. So they are a negotiated written agreement between one or more nurse practitioners, one or more physicians, and the healthcare system that specifies what functions nurse practitioners can perform, the scope of physician supervision, and circumstances requiring physician consultation. So for instance, a standardized procedure might say the psychiatric nurse practitioner doesn't require physician oversight of psychotherapy, but may require physician oversight of prescribing. And then it may sort of specify circumstances in which the supervising physician should be notified, such as a change in patient condition or a new patient, or if it's a team that's been working together for quite a long time, it might pretty much be, whenever you think you need to. The regulations require that the supervising physician, although they do not have to be on site, they must be available by phone. So there's two types of standardized procedures, disease-specific, which are kind of like protocols about how to treat different illness conditions. And these are a little problematic because oftentimes patients we're seeing, the diagnosis is ambiguous, and if steps that have to be followed are spelled out very clearly, there's potential for liability if it's not followed. So it doesn't provide a lot of latitude for clinical judgment. So process standardized procedures focus on circumstances that require communication between the nurse practitioner and the supervising physician. And as I said, that's pretty much up for negotiation between the parties involved. So I think this whole issue of nurse practitioners and scope of practice is a little bit confusing, and there are kind of a number of components that sort of go into looking at for any given nurse practitioner, what's sort of an appropriate scope of practice. So these are some domains that need to be considered in terms of looking at this. Does the nurse practitioner have the knowledge to work with this population or to fulfill these functions? Are they licensed and credentialed to do this? Do they have the training and skills? Does the healthcare environment support it? And then, ethically, is the safety of the client best served by the nurse practitioner accepting treatment responsibility, or should it be referred elsewhere? And one thing that I think has been kind of a common source of confusion is that NPs sometimes kind of get lumped together with physician assistants as quote-unquote mid-level providers. And physician's assistants, I think the relationship, the supervisory relationship, and the PA sort of functioning as an extender of the physician is really more clear. But and sort of being able to accept delegated responsibilities within the physician's scope of practice. But delegation by the supervising MD is not an important determinant of the scope of practice for a nurse practitioner. So for instance, if a nurse practitioner is educated and certified as a family nurse practitioner or primary care nurse practitioner and has no education or training in treating complex psychiatric conditions, psychiatric treatment would not become part of her scope of practice just because she's supervised by a psychiatrist. So NPs don't practice, under the license of a physician. It's a collaborative relationship with the Psych NP having his or her own scope of practice. So, so it's time for our first round of questions now. So,
thanks, Beth. So, everybody, this is Kim again. If you would like to ask a question, there is a raise hand icon you have in the control panel in the upper right-hand screen of your upper right-hand corner of your screen. If you just click on that, and Katie will call on you if you'd like to ask a question. You may also type your question into the question period. So please let us know if you have a question so far. And we will have another Q&A period at the end of this too.
Was everybody just stunned with all that regulatory information?
Looks like we have a question. Someone asked, can you speak more about the collaboration with the physician? I have had some physicians refuse to give advice to an NP because they are afraid they will be liable.
Yeah, I think that that's something that there's a lot of misunderstanding about. And although I think the use of nurse practitioners for primary care in California is well established. I think that, because the Psych NP role is a newer role, a lot of times psychiatrists have not had experience working with Psych NPs, or, have maybe worked, trained in different states where the laws are different. So I think it is something that can be very confusing. And I think that, I'm just trying to think kind of how to respond to that. The nurse practitioner is not practicing under the physician's license. I think that's really important to emphasize, because that's something that physicians often misunderstand. If the standardized procedures specify that a nurse practitioner is supposed to consult with a specific physician under certain circumstances, then I don't know. I don't really understand what the concern would be about liability. I don't know. Maybe you could say more about that.
Well, in the meantime, I have another question from someone asking how many PMHNPs have experienced treating severely and persistently mentally ill patients in an outpatient CMHC, especially those that require an FSP level of care, the most ill. What would be an appropriate caseload in such a setting?
Well, I think that really depends on the background of the specific NP. I think, and I'm going to be kind of generalizing based on our program, but I think this is true for other Psych NP programs in the state as well. We use a wide variety of different kinds of clinical placement sites. In our program, we have a long history of commitment to public mental health. So historically, a lot of our placements have been within public mental health settings, including FSPs. But, we also use the VA, we use Pfizer, we use community-based organizations. So it kind of really depends on the student and where they did their residency, and also, what experience that person may have brought into the Psych NP program with them, because some students have worked in those kinds of settings as RNs before they went into a Psych NP program. So, I couldn't really give you numbers on that. I think that certainly Psych NP students get trained in those kinds of settings, but it really depends on what kind of opportunities they've had to do residency placements there, and also what other experience they might be bringing with them from their previous professional work.
Great. I have a question. Actually, someone has raised their hand, so I'm going to unmute you, Vanessa, and hopefully you have a good connection. Oop. There we go. Vanessa, can you speak into your phone and ask your question? Oh, I don't seem to be. She seems to be self-muted right now. Well, she had followed up about the libel question, and she had asked, she had said, physicians have told me they are concerned about consulting with nurse practitioners because if there is a bad outcome, suicide or severe medication reaction, they fear they would be held responsible.
I have a hard time understanding why that would be a concern. Certainly, if they're getting the appropriate information and kind of exercising appropriate clinical judgment in terms of the consultation with the Psych NP, I don't know why why they would think that they were going to be liable. I don't know. I guess I don't really understand that.
All right. We have another question wanting to know, someone would like to know more about the payor requirement for billing. What is involved for an agency to get certification?
Oh, I was afraid you were going to ask me about billing. Billing's kind of a weak point for me. So I don't know about the agency. I know that Medicare that requires that Psych NPs have national certification in order to bill under their own name. I think I need to hear a little bit more about that question. I'm not really sure I understand what the person wants to know.
I think as a follow-up, she asked, placement agencies are concerned about revenue loss due to the physician's supervision time. Can we address this issue?
Okay. Yeah. And I think that how different agencies do their billing it's kind of a mystery to me, because we have students in so many different agencies, and it gets handled different. And then, of course, we have people in VA and Kaiser where they're not billing. So I would say that with students, I think this is true with other mental health professional students, initially, when a student starts, the person who's precepting them is going to have to invest some time and energy into getting them up to speed. But, as it kind of goes on in the year and the student becomes more able to, manage more independently, then the amount of consultation time that's required really goes down. So having the student there allows you to see more patients with less time of your actual paid staff. So, how that equation works out in different settings and for different students, I think there's quite a bit of variability there. But certainly, Psych NP students do bring the potential to see more patients as their need for consultation decreases throughout the course of the year.
I have another question saying, do nurse practitioners need to have a supervisor on site at all times?
Not necessarily. Sometimes actually, Psych NP students might be doing things that, that are actually within their RN scope of practice, so they don't necessarily require a preceptor presence. For instance, doing a psychoeducation group or something like that, the preceptor would not have to be present for that if the student already, kind of had sufficient skill to be able to do that.
And another question is there still a requirement for the physician to sign off on the nurse practitioner charts, or is that dependent upon the written agreement between the nurse practitioner and the physician? And is this the same for psychiatrists and nurse practitioners?
Okay, so let me just make sure I understand that question. So, the question is about Psych NPs and if the physicians have to co-sign their charts. And the answer to that would be no. For Psych NP students, yes, the preceptor, whoever it is, does usually need to co-sign the charts.
So, Katie, is that our last question for now?
That is the last question that has been sent to me.
Okay, so we'll continue, Beth, and then we will have another Q&A period at the end of the presentation. So go ahead, Beth.
Okay. So, so what we're going to talk about now is some actual examples of Psych NP roles in public mental health. And most of the pictures are from the UCSF School of Nursing magazine, The Science of Caring, and they show some of our alums because I didn't have to worry about copyright using these pictures. So, so the nurse practitioner in this picture is Kim Pellish, who graduated from our program probably about 10 years ago. So, so these are some examples of some public mental health agencies that use Psych NPs. I just kind of grabbed a representative smattering. And in most of these settings, the Psych NPs do a combination of med management and supportive psychotherapy. But that really varies from agency to agency. And I know that in the San Mateo County, their total wellness program, the Psych NPs really have a health promotion focus. And I think you can see that these agencies sort of span the age spectrum, and that Psych NPs are working with children, adults, and older adults. So as of next year, the national certification will require that Psych NPs be educated and trained to work with individuals across the lifespan. So so here's our pie chart again. And I just wanted to sort of use this to sort of visually represent that particular Psych NP jobs may not use the whole scope of practice. In fact, it's kind of hard to imagine a job where, where all these things would be incorporated. It may just sort of focus on one or two areas within the scope of practice. So I also wanted to talk a little bit about Psych NPs providing integrated mental health and primary care because I think that Psych NPs are particularly well suited for this, and I know that some of the counties are providing a lot of mental health services within primary care settings. So I want to talk a little bit about some examples of Psych NPs doing this. And the women in the multiple hats, this sort of represents the broad skill set, the multiple different functions that Psych NPs kind of take on in these integrated care roles. So this is just a few of the reasons why I think Psych NPs are really perfect for integrated care. Some of the things I mentioned before, the broad-based psychosocial approach that really looks at the person's total health, the ability to span medical and mental health care systems, the focus on human responses. And I also think nurses are very pragmatic. And the picture is sort of meant to represent nurses kind of being the duct tape that bridges the gaps in our fragmented care system. So in the literature, there's several models for how Psych NPs might contribute to integrated care, and I think some of these are similar to how other behaviorist models for other mental health professions where the roles either focus on consultation and education, the primary care providers, it's mostly an indirect role, having Psych NPs on site embedded in a primary care practice to provide mental health services, or a collaborative model where the Psych NP might be getting referrals from a variety of different primary care providers. The one that I think is more unique to nursing is the integrated model, where the nurse practitioner is trained in both mental health and primary care and provides integrated mental health services. So they may be seeing patients with kind of complex medical and psychiatric conditions, or they may be kind of spending part of their time providing primary care and part of their time providing mental health care. Or, the model may really incorporate aspects of several of these different models. So I want to just mention a few settings that use Psych NPs to provide integrated health services. And the first two of these are faculty practices of our department in the School of Nursing. So the first one is Glide Health Services, that was founded about 16 years ago as a partnership with Glide Methodist Church, which is an inner-city Methodist church that provides a lot of social services, and the School of Nursing and Catholic Healthcare West, which is now Dignity Health. So it's currently an FQHC. It's a fully licensed nurse practitioner managed clinic that provides a range of services, which I'll talk about in a minute, for a very vulnerable patient population that has a high rate of mental illness, and it's in an inner city neighborhood where there's a high rate of drug and alcohol use and crime, and a lot of the patients that go there are homeless as well. And nurse practitioner on the right in the picture is Esther D. Lagon, who's a graduate of our program. So these are the services that are provided by Glide Health Clinic. As you can see, it's pretty comprehensive. And the model that they use allows them to integrate mental health and substance use services into primary care visits, as well as providing dedicated behavioral health services. And GLIDE recently began implementing a major quality improvement initiative to improve depression management as part of a collaborative electronic health record project with the Institute for Nursing Center. So they're pooling data with a number of other nurse-managed centers around the country. And another thing that I think is kind of unique is that GLIDE Clinic offers integrative therapy such as acupuncture, as well as kind of a more standard package of healthcare services. And they do use a lot of volunteer services by community providers. And then the next example is the nursing faculty practice at Progress Foundation that's called Primary Care Outreach to People with Mental Illness. And basically this is a program where nurse practitioner practices provide on-site health services to 11 of these residential programs. And the pictures are the houses where the residential programs are located, and there's a number of different NPs that serve these houses, and provide over 250 visits per month. So for those of you who aren't familiar with the Progress Foundation, their philosophy is to provide rehabilitation and encourage self-sufficiency for individuals with mental illness. And the nurse practitioner practice started to help facilitate the transition between hospital and these community placements for people who would be coming to the residential settings, but who had medical conditions that required a greater degree of medical knowledge than the paraprofessionals who worked in the house could really provide. So, so this is a setting where a lot of our Psych NP students get their training in comprehensive health assessment. Where they work with faculty nurse practitioners in these programs. And again, a pretty comprehensive range of services that are provided on site, assessment of urgent health problems, chronic disease management, psychoeducation and health promotion, consultation and education of the staff. That's a really important function. And then programmatic interventions to promote healthy habits, such as, looking at the meals that are served in the houses, if there's ways to sort of decrease the amount of saturated fat and concentrated sweets. So those kinds of things. Looking at the physical environment and safety risks within the physical environment. Dealing with things like outbreaks of head lice, that kind of thing. And this practice has also been a place where some nursing research has been done about health promotion for people with persistent mental illness that demonstrated improved healthcare outcomes. And then here's a couple of more of our graduates here, Matt Tierney and Dina Seahand. And Matt's he's a Psych NP, and he's the clinical director of the office-based buprenorphine induction clinic, which is in San Francisco. And basically, because buprenorphine is a therapy for people who are addicted to opiates, and it has a lot of advantages over other alternatives. But the induction period, when people are first being started on buprenorphine, people require pretty close monitoring. So, so basically, they come into this setting and are assessed, started, and stabilized on buprenorphine and then referred back to their primary care mental health care provider to be continued on buprenorphine. And this is kind of another way of sort of looking at the model. But I think that what makes the Psych NPs particularly useful providers in this kind of setting is that it really capitalizes on the comprehensive physical and mental health assessment that needs to be done in the setting. A lot of care coordination, because it's obviously interfacing with a lot of different other different health and social service agencies. There's a real emphasis on patient engagement and motivation. And the NPs that work there do a lot of health education, particularly around harm reduction issues such as, avoiding transmission of bloodborne pathogens and that kind of thing, as well as a lot of supportive psychotherapy. So it's a real, it's a setting that really capitalizes on this very broad-based skill set that the Psych NPs have. So, so this is my last few slides here, and these are some of my suggestions about ways that public mental health systems can effectively recruit, retain, and use Psych NPs. And I know that some of you will sort of recognize some of the the problems I'm about to describe. So in terms of recruitment, having position descriptions that are consistent with the Psych NP scope of practice is important, and I know in some counties this has been problematic because they've been kind of stuck with a nurse practitioner position description that really describes a primary care nurse practitioner, and it's been difficult to get a position description approved that's more specific to behavioral health. And then another suggestion is to develop graduate clinical placements for students while they're in their Psych NP program, as well as postgraduate residencies. And the Future of Nursing report, this Institute of Medicine report, one of their key recommendations was to establish nursing residencies, because both at the undergraduate and the graduate level, oftentimes that first year out of the program is kind of a steep learning curve, and it's a time when nurses can really use some additional support. So hopefully more funding will follow this recommendation. So far the amount of funding has been kind of limited, but hopefully that's an area where we might be seeing some funding proposals come out. And then another kind of innovative idea would be to establish joint appointments with clinical faculty in Psych NP programs. So this could be in the form of a contract with the university for one of these Psych NP clinical faculty members' time. And I think that if your agency is sort of wanting to start including Psych NPs in the mix but doesn't have them and is really trying to figure out how to make that work, this might be a very viable model in terms of kind of developing Psych NP positions. So the Psych NP faculty would be somebody who is already kind of pre-screened for their clinical expertise. The university would be taking care of the, HR. It would be kind of a contractual arrangement. And it allows agencies to have some kind of flexibility in terms of hiring, because it's more of a contract arrangement rather than somebody who would be hired as an employee. And the amount of hours could be kind of flexible. So a Psych NP faculty in this situation could be an expert and champion for the use of the Psych NP role within the organization and provide expert consultation about how to structure positions to make best use of the talents of Psych NPs who might be hired, as well as providing advice on position descriptions and standardized procedures and some of that regulatory stuff. And then the faculty could also function as a dedicated preceptor for Psych NP students. And this could be advantageous for the agencies, as well as addressing a kind of a systemic bottleneck for training more Psych NPs, because in general, the biggest barrier to training more nurses, both at the undergraduate and graduate level, is lack of faculty, because faculty positions don't tend to pay as well as clinical positions. So, creating some of these positions that sort of combine faculty responsibilities and clinical work could potentially come up with with salaries that are a little bit more competitive, and consequently better retention of nursing faculty and ability to expand the number of Psych NP students who can be trained. So, so just in terms of optimizing the value of Psych NPs as part of the behavioral health team, I think utilizing the full scope of practice, or at least utilizing multiple components of the scope of practice, makes positions more interesting for Psych NPs and may help with retention, as well as allowing Psych NPs to make their maximal contribution to the team. And I think that really capitalizing on the nursing expertise that's part of the role is important, because I think for agencies who are really desperate for more prescribers, having an exclusive focus on just the prescribing part of the role might sort of minimize some of the other contributions that Psych NPs can make. So, so I want to just end with another quote from this article that was comparing practices with physicians only, physicians with NPs, and physicians with PAs in terms of diabetes management. And they found on pretty much all the outcome measures that the practices that had NPs as part of the team had better outcomes, which was, I think, not something that they expected to find. But their explanation for this contribution to quality was that NPs may add new perspectives within a team of clinicians because of their background in nursing, as well as their emphasis on the well-being of the whole patient, prevention of illness, and patient education. So, so that's kind of the end of the formal part of the presentation. So I'm interested, I'd be happy to answer more questions, and also if participants on the call have comments that they'd like to make about ways that they've sort of optimized the usefulness of Psych NPs in their own agency, I think that would be a great contribution to the discussion.
Great, thanks, Beth. So if you would like to either make a comment or ask a question, you can do it a couple different ways. You can click the raise your hand icon, or you can type it directly into the question box, and we'd love to entertain your thoughts and feedback at this point.
I do have one question already. It said, over the years, I have worked with several Psych NPs, and I have been impressed by their psychiatric knowledge and skills. However, I have found myself concerned by how little medicine they knew. How much internal medicine / primary care do Psych NPs get?
Yeah, that's a good question, and that will vary somewhat from program to program. I know that in our program they get, not a huge amount, but a fair amount. They do take coursework in comprehensive health assessment. They have a course that's kind of focused on common coexisting health conditions that people with mental health and substance use conditions often have. And then they also take a chronic disease management course, that focuses on things like hypertension and diabetes and so forth. With the goal not that they're going to necessarily be the primary person managing those conditions, but that they need to understand how to monitor them, how to refer, how to perhaps co-manage those conditions. But that kind of really varies from program to program. I know that there are other programs that don't have as much content on on medical conditions. So if that's sort of a desired attribute that you would want in a Psych NP in your setting, that might be something that you'd want to focus on. I mean, it's also true that that students bring some of that background in with them, because a lot of times, nurses work in a variety of different kinds of settings before they come into a Psych NP program. So they may have, med-surg hospital experience, or, they may have had other kinds of experience case managing patients with complex medical conditions or those kinds of things. So I would say that that's variable from program to program, as well as being variable depending on the background of the Psych NP. So if that's something you're looking for, that's something you should definitely mention in your job description. One thing that I would like to mention in terms of NPs that have integrated preparation in psych and in primary care, certainly some people have graduated from integrated programs where they really get training in both of those things. And then there's also a pretty steady flow of people who are initially trained as primary care NPs who discover that there's a lot of psych involved in primary care, and then go back and get an additional certification as a Psych NP. So, so if having a good background of medical knowledge is important in a particular role, that might be the kind of candidate that you'd want to look for.
And I think I don't know if somebody asked this before your answer, I think it's related, is managing coexisting health disorders mean that Psych NPs can actually treat primary care or medical problems as well?
Well, the answer to that is kind of a little bit complicated, and it kind of goes back to those domains for making scope of practice decisions. And the boundaries around what's considered Psych NP practice and what's considered primary care practice it's kind of a moving target. Certainly on the primary care side, primary care providers are managing a lot more in the way of psych problems than they used to, and I think that trends such as the increase in metabolic syndrome because of second-generation antipsychotics have sort of made it more important for Psych NPs to have some knowledge and skill in assessing and monitoring those conditions. As to whether in a given setting it would be appropriate for them to manage these conditions, again, it would depend on their education and training, maintenance of skill, and if the specific focus of the agency supports that. So it's something that I think you kind of have to look at on a case-by-case basis. You have to really look at the individual person and their background as to what they could manage. I think this kind of becomes an issue sometimes because some patients who are treated in public mental health settings may be unwilling to go to primary care to get some of these other health problems dealt with. So, it may be a situation where the psychiatrist or the Psych NP, manages some of these problems with consultation from a primary care provider because the patient just won't go to primary care. So, so there's not really a simple answer to that question. I think you just need to look at the, does the person have the knowledge and the skills to be able to do this, and does the mission of the agency support it?
Great. I have somebody else is wondering if you would repeat that final quote, please, regarding the improved outcomes in diabetes care.
Yeah, and this is in, the last slide is references, and this is from the article by Oman Strickland et al. NPs may add new perspectives within a team of clinicians because of their background in nursing, as well as their emphasis on the well-being of the whole patient, prevention of illness, and patient education.
Great. Someone has a comment about they've identified a few programs and agencies that are interested in working with PNP graduate students, and they are hoping you can help them set up the programs.
Great. Great. Happy to do that.
Another question is, I know there is a great variety in different settings, but if we are thinking of trying to establish a PMHNP position, where would we find salary comparisons? What about differences between PMHNP and other NPs?
Yeah, that's actually a really good question. And, I don't know that, just in terms of salary surveys, I don't know that there's a lot of data on that because Psych NPs are a relatively small group. I think what a lot of agencies tend to do is to look at salaries for primary care NPs, but just like psychiatrists tend to make higher salaries than primary care docs, Psych NPs tend to make higher salaries than primary care NPs because that's just how it is, whether it's rational or not. So I think that's something to look at. I think another way to think about kind of coming up with salary figures is that, and I didn't get into this whole billing thing because I'm not really an expert on billing, but there's two ways that nurse practitioners can bill. They can either bill what's called incident to billing, where it's billed under the supervising physician's name, which means that the supervising physician has to see the patient, in which case they bill at 100% of the physician rate, or the nurse practitioner can bill under his or her own name, and that's at I think it's 80 or 85% of the physician rate. So that's kind of a ballpark for thinking about Psych NP salaries is, what's 80 to 85% of what you would pay a psychiatrist.
Another question is, what time of the year does UCSF have graduates that are ready for placement for internships?
We're actually going to be getting started doing placements. We start at the end of January because, with agencies having more and more requirements for fingerprinting and computer training and stuff, we've been starting earlier and earlier. It's kind of like Christmas shopping after Halloween. But the students, we kind of work during the winter and spring to get residency placements set up that either start in the spring or, in the summer or in the fall. So generally, it seems like most places that have training programs, they have the trainees start beginning of July or beginning of August. So that's around the time when most of our students start. But some places prefer to have them start at more the beginning of September. So it's anywhere from mid-June to early September is when they would be starting their residencies.
And another question is, and a follow-up to that one, who is the contact person to arrange for a contract and placements?
So at UCSF, it would be me. I don't think I put my email address on here, but it's beth.phoenix@nursing.ucsf.edu. So if we don't have a contract with your agency, I would initiate the contract request. Usually what we do is, before we set up a contract with an agency, we visit the agency, we talk about what kinds of experiences the agency can offer, what kind of supervision they can offer the student. So for UCSF, it would be me. There is also, they just started this past summer, but the University of San Francisco, which is a private university, just started a Doctor of Nursing practice level Psych NP program. I don't know whether their students have started doing clinical placements or not. And if people are interested, I can find out who's responsible for their placements as well.
And then another question is, what forms of psychotherapy training do students get in your training? And do they get training in motivational interviewing?
Yes, they definitely get training in motivational interviewing. All the advanced practice nursing students at UCSF get training in motivational interviewing. They have a day-long workshop, and then we also cover that in some of the psych courses. So that's probably one of the ones that they get the most emphasis on. They get exposure to a variety of different therapeutic approaches. What they actually get to practice kind of depends on where they do their clinical placement. So I would say that we emphasize sort of brief, structured approaches to psychotherapy, CBT, DBT, things like that. Not so much psychodynamic, because I think the training requirements to really develop skill in that are more intensive usually, although some of our graduates do go on and get more additional training in that. So, but I think that a lot of what nurses bring is kind of a good fit with sort of educational and skill-based approaches like CBT, because nurses have so much of a focus on patient education and symptom management. So I think that's a real natural fit. And I think also that kind of humanistic psychotherapy approaches are also a good fit, because in nursing theory, there's really a lot of emphasis on the nurse-patient relationship. And, I don't know that the term unconditional positive regard is really used in nursing theory, but I think that concept is something that's important there. And, I think that nursing has a big emphasis on therapeutic communication. So I think I think that humanistic psychotherapy approaches are kind of a natural fit for nursing. So I guess that's what I'd say about that.
And that is all the questions I have received.
All right. So it sounds like that we've gone through all the comments or questions. And Beth, why don't I do this? Why don't we add your email address to the slides at the beginning? Would that be okay with you?
Yeah, that would be great.
Okay, so we will add Beth's email address, and we will send out the slides as a PDF to everybody who attended today. I want to thank Beth for a great presentation. I want to thank you in the audience for participating today. We encourage you to take a few minutes to share your feedback. You'll get a pop-up survey that you'll get. And with that, we're going to